right, perfect. And then whenever you're ready.
All right, so we have a three-person team presenting today. So I'm Laura Lander, social work faculty in the Department of Behavioral Medicine and Psychiatry at WVU up in Morgantown.
I'm Amanda Newhouse. Also social work faculty at WVU Medicine in Morgantown.
And I'm Kristen Boyce. I'm also social work faculty at behavioral medicine in Morgantown as well.
And we're going to talk about family treatment. So I will share my slides. The overview is that we will talk a little bit about the prevalence of substance use disorders in the United States among families and how it affects families. We'll review the current foster care numbers in West Virginia, and then really transition into why family treatment, like how is family treatment so different than individual or other kinds of treatment that can be beneficial to individuals with substance use disorders, families experiencing that, including foster care placement, out-of-home placement. We'll go over the three primary evidence-based models of family treatment. And one of the challenges is that we don't have a lot of people trained in the state in these models, which we're hoping to change in the future. And then we do have three cases that we've been thinking about in the context of this didactic, but if you guys have any cases you want to talk about, we would be happy for just people to volunteer to do that off the cuff. You don't have to have submitted anything. I think hearing from the audience is always beneficial. So the overall prevalence this is from the National Survey on Drug Use and Health, is almost up to 50,000 individuals with a substance use disorder in any given year. And so this was from 2022. And the breakdown is almost even, and this is different. This is a shift to more people using drugs than alcohol. Alcohol, obviously, we think of as a drug, but when we think about substance use disorders, the prevalence of alcohol use disorder used to be much higher, and it's almost even now. What's driving that is really cannabis use and the disorders evolving from cannabis use disorder and also methamphetamines, although the numbers are much smaller with methamphetamines. And then about 8 million people had both alcohol and drug use disorders. The sad news is only 1 in 4 people actually get treatment for those use disorders. So access and uptake, like even if it's accessible, people aren't engaging in treatment, are not where they could be that would be beneficial. And when we think of one person with a substance use disorder and the number of family members or loved ones that affects, it means almost 2/3 of Americans have someone in their family that struggles with a substance use disorder. So that is a lot of people. And the argument for a family intervention, what we know from some of the interventions, specifically the CRAFT model, is that if you engage the family in treatment, even without the person with the substance use disorder, it can have a positive effect on the entire family and may have the effect of bringing the person with the substance use disorder into treatment. So Kristen will talk more about that model. And about 1 in 5 children grow up in a home where there is someone who misuses drugs. So I think of this as the ripple effect. So you start with a single person in the middle, and it really ripples out to families, certainly ripples out to entire communities that are affected. We've seen that really profoundly from all of the overdose deaths in communities where they've lost so many young people. So family therapy really is informed by something called systems theory, which posits that it is beneficial to understand an individual in the context of the systems they function in. The family being one of those, the community is another, the workplace might be another, but the family system is kind of the inner circle, that closest circle to the individual and the people which are most influenced by any one individual. And then when we take in consideration the family system, we can actually have the most effective interventions. And family members are significantly impacted by substance use disorders. Physically, often family members develop physical problems as a result of the stress and worry and fear connected to having a loved one that has a substance use disorder. And they absolutely need treatment, sometimes independent of whether their loved one gets help or not. We know that there's self-help programs, so peer support for family members like Al-Anon or Nar-Anon, and other kinds of peer supports that we encourage family members to attend, even if their loved one is not pursuing treatment. In terms of the number of people that are affected by substance use disorders who also enter into the foster care system or come to the attention of CPS, very high at 83%. So any given case that gets presented to CPS, as the folks at CPS know, it's often, more often than not, involving substance use disorders. And when there's a substance use disorder, there's often a co-occurring mental health disorder, and coordination of those services for kids and parents is really, really important. And there are barriers to those, barriers being time. If the person works, there are already so many things that an individual needs to do to, say, if their children have been removed, get their kids back. And treatment is one of those, but time can be challenging. High CPS caseloads for workers to try and manage all of these services and coordinate them. Lack of informed consent. So people have to sign consent forms for these entities to be able to talk to each other. So for the treatment provider to be able to talk to the CPS worker, certainly. Sometimes there's even mistrust, not only between, say, the individual involved with CPS and some of the systems and entities like the court system, but between, say, the court system and the treatment providers. Like there can be mistrust among people who we hope could actually collaborate together. Understanding addiction is sometimes a barrier. We know there's a lot of stigma, including in the legal system, towards individuals with substance use disorders, and see it as simply bad choices versus actually a brain disease. And then people are not always compliant with the recommendations that CPS gives, including treatment. And so that can be a barrier to reunification and getting well. So communication is just really important between what could potentially be all of these multidisciplinary team members. So I don't know if you guys have ever seen any of these findings from the West Virginia Budget and Policy Report. They are very active right now in trying to advocate for not cutting Medicaid and putting out a lot of numbers around that and how that would affect West Virginia. But they do these reports, and this one in particular was on the foster care system and recommendations about how to improve things. And they talked about what we know, which is parental substance use is often a factor when there is a child removal and a child is placed into foster care. And it's also highly correlated with poverty. And so children who come from families that are experiencing poverty are more likely to be removed from those families because of the lack of resources and because of what may be neglect because they don't have some basic needs that are being met. So if we target poverty along with treatment of substance use disorders, it will be beneficial, like kind of a two-pronged approach. West Virginia places more children in the foster care system than any other state, which I was surprised at. So this is per capita, about 13 per 1,000 children are in foster care in West Virginia, and that's nearly double that of the next highest state. And then West Virginia also terminates parental rights more often than any other state and more quickly. And so this my question was like, why? What is happening for us that's different than other states? What are states doing that might be different, and what are some ways to reverse this trend? I do not have those answers, unfortunately, today, although we're going to suggest that perhaps family interventions could help. But it's a question that I really pose to the group. And then just some statistics on the current status of children in foster care, currently a little over 6,000. That I looked on the CPS website. That was in March. Good news is this is down from, there was a really high foster care placement rate during COVID. We certainly saw an increase in substance use rates and overdose deaths during that time, which correlates with placement. So about 1,000 fewer children are in foster care today than in 2021. And the ages, we know that child removal and placement into foster care can be more traumatic for everybody, for the children, for the family. When children are younger, and the younger they are, the more significant those health effects might be on their mental health. So a little over a third of kids in foster care are under the age of 5. And then time to reunification in West Virginia. So 58% of kids are reunified with families in 12 months or less, and then 32% in 24 months or less. One of the things we always worry about is, well, if we reunify, are the kids going to be okay? Is there going to be another problem? Will they have to be removed again? And those numbers are actually pretty low. So only 6% return to foster care within 12 months and 10% within greater than 12 months. So I actually see those as pretty solid outcomes. So I'm going to turn it over to Amanda.
Yeah. So when we think of why family treatment, if you look at recovery as a whole, it's a parallel process, right? And so it really impacts everyone within the entire family system. And when we look at that parallel process, there's individuals who are impacted that are using the substance, and individuals within the family system that have caregivers or family members that are substance users that are impacted significantly. So everyone's perspective is really important. When we're looking at the entire family system, it becomes a pattern of interaction. And so what happens within families is we have to change unhealthy patterns of interaction to healthy patterns of interaction. And sometimes we don't even realize they're unhealthy patterns of interaction, right? I bet if all of us kind of think of our patterns of interaction with family members, we can think of a couple that are unhealthy, right? And we don't even know how that happens. Like, you have to think to yourself, like, how did that even get there? But changing that can impact everyone. So the individual who's using substances, sometimes those unhealthy patterns of interaction can be huge triggers. So if they went off independently and received treatment, came back into this family system with the same patterns of interaction, they're just going to be triggered over and over again. The same thing with individuals within that family system that could have been traumatized or impacted by the substance use disorder. Once that individual returns into that family system, they could be triggered again. And so it's really about healing the entire family system. Okay, next slide. All right. So when we're looking at family treatment, I want you all to take a moment and just look at this picture and tell me what you see. Say it out loud, type it in the chat. What do you see in the picture? Can you all see the picture? Kelly says a mess. Very messy. Chaos.
I see fruit.
Fruit. Yeah. Deborah says fruit. Absolutely. Depression. The little boy's happy to see his dad. Yeah. Family together in the home. Yeah. Yeah. So I think it's, when we think of family treatment, we want to start looking at a strength-based approach. And it's really important to start looking at strengths so that we can overcome some of these barriers and weaknesses. So it's really easy for us to look at a picture like this, or even go into a home that might look like this, right? And say, what a mess. But really, if we look at this picture, it's a 2-parent household, protective factor, right? There's fruit available, all kind of food available, protective factor. The little boy is really happy to see dad come home. And we know that one of the pieces to assessing attachment is upon reunification. So we see that with him. He's really excited to see dad. The kids have toys, they're entertained, right? The dad's working. These are all protective factors. And so, really looking at some of these strengths and kind of bypassing. So, I mean, we always have to ensure safety, right? So I don't want to discredit that throughout this presentation. We have to ensure safety. So, I mean, there's heat, but I mean, like we sometimes we see the clothes close to the heater, the knife on the counter, right? Like sometimes our eyes are drawn to those things, but really trying to look at the strengths while addressing some of that safety can be beneficial. And so moving more of a strength based than deficit and looking at what's wrong and helping them overcome some of those pieces by finding what they're doing well. Okay, next slide. So when you look at some of the impacts that can happen from, like Laura was talking about, like removing children, especially kids 5 and under, right? We know that there are major attachment pieces that happen within that first 5 years. And it can be very traumatizing for families anytime you disrupt that family system, right? And so we know that removing children disrupts the already established relationships that have formed, and they have to rebuild those relationships. Trusting those attachment figures can be huge, and this all depends on where the child is within their development. And if we look at 1/3 of children being 5 and under, that's a pretty big impact, right? And so children who are removed under the age of 5, that trusting attachment figures is huge. And if we're removing them as infants, that's even bigger, right? Because now they're having multiple moves and multiple placements where they have to reestablish that trust and build those relationships, which is going to impact their development and sometimes delay it. And if you like, I use visuals. I have like Eric Erickson's 8 stages and Piaget's stages to identify with families where their kids are within those developmental frameworks. Because even though a child might be 5, social, emotionally, and developmentally, they may be functioning at 3, which is completely different. And we need to understand this to approach that attachment and build that and to address some of the trauma issues as well. So if you think about it, like think about object permanence, right? Object permanence for an infant occurs between the ages of 4 months and 8 months. And object permanence is just when they start to identify, like, mom and dad go to the bathroom, they're coming back, right? They've not deserted me, they're coming back. Or if they go to work, they come back around 5. Cognitively, do they know that? No. But do they start to feel that time frame? Yes, they feel everything, right? And so that object permanence sets in. Imagine an infant being removed before they've developed that object permanence, right? So they've not been able to trust that attachment figure because they've not developed that object permanence. They're removed and then reunified. They're going to have a harder time trusting that attachment figure, not only because they've been removed and their family disrupted, but because this developmental stage was not even met yet. And so it's going to be a little more difficult. And so us understanding that, I think, is huge, because sometimes as providers, we look at that and think, well, they must be doing something wrong because it's taking a really long time for them to attach, or but it might be something within development. There's a lot of complex issues that can happen between birth and 7 years old that would impact that ability to attach. And so it has a huge impact. That safety, security, predictability is so necessary for kids to build attachment. And so a lot of the times when a child's removed, there's so much disruption that they don't feel safe and secure, and things are so unpredictable in that time frame. So it can be really difficult. The length of time that they're in foster placement has a huge impact too. For kids over 5, frequency of visits is really important. 5 and under, they don't understand necessarily the frequency, but the quality of the time that's there. And so those visits are really important. And to build those relationships, you have to increase that frequency. But again, as long as safety is not a concern, right? We want to try to make this as possible as we can. And looking at the nature of the relationship prior to placement, what was that like? Taking that into consideration as we continue to move back towards that, and even the presence of kinship and foster attachments, right? So the smoother transitions are the ones where kids know maybe the kinship care they're moving into once removed, right? So we see if they've already built that secure attachment, moving into a kinship care, right? That's a little bit smoother. And that's why we always look at kinship care first. But even if these individuals stay in their lives, like foster parents staying in their lives as they go towards reunification, we see higher success rates with that and easier transitions, and lower risks to mental health disorders later on as well when these attachment figures are staying involved in these children's lives. Has a huge impact, right? They've been in their lives. Okay, next slide. Some important factors to look at when working with families who've had a child removed, like we talked about, looking at that developmental stage and understanding how that impacts the child and the family, right? So families are in different stages as well. And what stage are they in? Are they in the child rearing stage? Are they in the nesting stage? Like, what stage are the families in? And so it's really important for us to understand what stage each individual's in so that we can gain perspective of each as well. Making sure that visitation is occurring. Unfortunately, our system doesn't allow visitation to be consistent, but man, would that have such a huge impact on kids if we could have consistent visitation. Unfortunately, you have high caseloads and difficult schedules that just doesn't allow that to happen. You have families that are integrating into work and other systems that just doesn't allow that to happen. But it would significantly increase that predictability and consistency that would reduce stress, anxiety, and any type of mental health, well, I shouldn't say any, but some mental health concerns later on, right? If we could just increase some consistency with that visitation. Also has a huge impact on parents as parents are doing well, increasing their visitation options, right? That motivates parents. And we know, especially parents who struggle with a substance use disorder, just like contingency management is an incentive. Once parents start doing well within their treatment plans and understand their treatment plans, increasing visitations would just motivate them to do even more. Sometimes this takes having those supports, and a lot of the times the families we work with, they come from families that aren't really great supports for them. So helping them find some of those support systems and their tribe, right? Their individuals who are going to help them with this as they continue to work towards reunifying their family. Um, yeah, so next slide. When we look at so family treatment, most family treatments are derived from utilizing and looking at the entire family system. So many family treatments pool in the family systems theory, just identifying that each system impacts one another, right? And trying to take that perspective and understanding from each individual. And when we're working with parents who've struggled with a substance use disorder, we have to take into consideration that factor of shame and guilt. That's a huge barrier. And so we have to really understand how strong that shame and guilt is with those individuals, and overcoming that. I think I've worked with, you know, I've done a lot of family therapy cases and worked with parents with substance use disorder. And I think over the past 10 years that I've been working specifically with families with substance use disorder, I've had one parent that's overcome that shame and guilt. It is so hard to overcome that shame and guilt of the substance use that may have led to your child being removed or during pregnancy, or conceptualizing that everything wrong with your child is because you use a substance, right? Like, so this shame and guilt really runs deep. and I think it's a huge barrier, but it's a factor that we have to take into consideration because it comes within into these patterns of interaction, right? It can impact these patterns of interaction within the entire family system. Parenting confusion. So a lot of the times as we're moving towards reunification or even visitation, and depending on the child's developmental stage, sometimes there can be parental confusion of who the parent is, who's in that role, right? And even with, we see parentified children. And so we see children that are sometimes, as young as like 6 or 7 that move into this parental role, depending on the situation and how they've had to manage some of their siblings. And so that's where we see, if we look at some of the child factors, we see some anger come in with that, especially with some of our teenagers. We see our teenagers who now they have to move out of this parental role and a parent moving into the parental role, and they're fighting big time, right? And that's really difficult. And that's why I think family treatment is super beneficial, because that's another factor when you look at that, like that can create a lot of dysfunction within the family system. And a lot of the times we think, what's going on? Like something's still not going right, right? There's a lot of conflict. Well, it's really difficult to move a parentified child from that role. And the only way you can do that is by elevating the parent. And when parents are coming in and being reunified with their children, and they're holding on to this guilt and shame, a lot of the times that's where we see some permissive parenting, right? They have a hard time setting up some of these boundaries and rules because they feel so guilty for what they've done. And so you can see where some of these unhealthy patterns of interactions are starting to be created. And family treatment can kind of intervene with that and create those healthy patterns of interactions. Can be super stressful and overwhelming for everybody. So not just for parents, but overwhelming for everybody. And thinking of the parents, working so hard for this reunification. Everybody wants to move towards reunification. And then when the family system comes together, there's this stress and it's just not jiving right away. And it can be really difficult. For children, there can also be a feeling of rejection, right? And that becomes a cycle. So if children feel rejected, sometimes we have children that are placed back into the home before others, right? And they may not understand that or conceptualize why they're able to be there and why they're not. And sometimes there's a sense of rejection that their parents have rejected them, or caregivers rejected them, or siblings have rejected them, right? And what happens is they shut off to those relationships and interactions. And then what it can do is cause that other individual to feel rejected and shut off. And so then you have two emotionally shut down individuals, and it just creates this unhealthy pattern of interaction. And understanding substance use disorder for children. I can't tell you how many children I've worked with, and they've been in families who've struggled with substance use disorder for years, and nobody's ever talked to them or educated them about substance use disorder. So the assumption is that they live it, they see it, they should know it, right? Not necessarily. And so a lot of the times that education relieves this huge burden of just the unknown for them. And so if we think of that safety, security, predictability, right, it makes things a little more predictable when they understand it. And of course, like we talked about, roles, rules, and boundaries. And so we see that with a lot of family systems. Okay, next slide. And so just kind of recapping some of that, benefits of including family is definitely influencing change within the entire family system. Having a lot of that support towards those healthy interactions can be beneficial, and reducing those unhealthy or dysfunctional patterns of interaction can help all around, right? On both sides, from maybe triggering some of that trauma, triggering a substance use, right? And so really changing those patterns of interactions and reducing, generational substance use disorder. So stopping it and not repeating those patterns, promoting that homeostasis and healing within the entire family, and doing this all through their strengths, right? Finding what they're good at, find out what they're doing well, and promoting that and using that to overcome some of these barriers. Okay. Next slide. Our our substance use disorder treatment for families, right? So we look at it in three senses, right? A parallel process. So when you're talking about family treatment, you're talking about an individual who's struggling with a substance use disorder receiving that individual care, right? This is their parallel process. They can receive that individual care while family members are also receiving treatment. And so that's that parallel process. Everybody kind of working on themselves in this parallel way. And then we look at integrated care where you're integrating that while you're working on yourself in this parallel way, integrating with family treatment. And so pooling some of those pieces in together and then working together. Or you can look at a sequential way, right? Like once you've worked individually on your substance use disorder and you've sustained yourself in recovery, then moving towards family treatment. Or, once individuals within the family have worked on some of their trauma and the other individual with a substance use disorder worked on their substance use disorder, then moving towards family treatment, right? And so you can do it in a sequential way, integrate it from the beginning, or work on that parallel process. Okay, next slide. And then when we think about just some of the core pieces of family treatment, cognitive behavioral therapy is something that's utilized within family treatment, not standalone, but changing some of those thought patterns is really important for building on that communication and changing and interrupting those unhealthy patterns of interaction, right? Because it's easy to kind of spiral down those negative thinking patterns. And so CBD just kind of CBT tries to help it sounded like CBD, but I said CBT. Changes those patterns of interaction. Okay, next slide. And then just understanding, so the chronic disease model is just understanding that this is a disease, right? Some of those educational pieces with family members to understand this is a disease, how it impacts individuals, how it impacts their behaviors, their relationships, their emotional display, and how much those patterns of interactions can change once an individual is starting to get healthy. And so helping families understand that as a whole. Okay, next slide. Okay, so and I'm going to be turning this over to Kristen. Kristen's going to really hit on these family treatment models. So like Laura said, the brief strategic family therapy, multidimensional family therapy, and craft are evidence-based models. And then systems theory is really pulled into all of these. And so she'll go over the multisystemic family therapy as well. All right, Kristen, all yours.
Thank you. Thank you. So we're going to first kind of talk a little bit about brief strategic family therapy. So this is a therapy model that is relatively short term. It's about 12 to 15 sessions over about 3 months. It can be extended depending on the family's needs. So recognizing that it can be culturally appropriate. If we need to change things, adapt it, we can do it. It focuses more on youth, or youth within the family of 8 to 17. And it works to interact and target those patterns directly related, more specifically to the youth's behavioral problems, whether it's substance use, delinquency, being argumentative, emotional, behavioral, can really target those pieces. I included this graph on the left to show kind of the process in which brief strategic family holds. So there's this level of joining. So you want to be welcomed into the family, become a part of the dynamic. So this is a model where we're going to involve all members of at least the nuclear family. So I want to be welcomed into it. I'm going to have a lot of enactments happening. So I'm going to sit back and kind of going to watch how the family dynamic behaves. We want to have this as that understanding of where those patterns are coming from. Amanda mentioned the patterns of behavior earlier. Sometimes they just happen and we don't know that. So as the outsider welcomed into the family, I'm going to work on recognizing those things. And then instead of diagnosing one person in the family, we're diagnosing that interaction. That's going to be where the treatment is going to take place. We then, as a team, collaboratively within the family, come up with what that treatment plan looks like. And we continue to have those enactments. We have a problem, we work to address it. And this model is very directive. So I might then jump in and be like, oh, nope, we're not going to do that. We're going to try it in this way. So it's a little bit more, that's where the strategic piece, it's strategic in that process. We're going to work to change the behaviors in that setting, typically within an office setting. Next slide, please. So the evidence base for brief strategic family therapy is really, really good, recognizing that, so this helps target youth who are struggling with substance use. It actually has a high rate of like fully completing the program, I think, just the importance of the joining. A lot of times we have families come in and they kind of feel like they're thrown into family therapy and they don't know all of the pieces. They don't know what they're getting signed up for. So we have a lot of dropout. So the importance of recognizing we need to be a part of the team. They need to be a part of the team. They are the experts of their lives. So there's a long, high rate of them maintaining presence within the program. It also helps build pro-social activities. So we see a reduction in those antisocial peer relationships with youth. So we're working to change those family patterns, again, not just with the family unit, but even with the other systems that are in that. One of the things that I don't have listed on the slide, but I think is really important to talk about, in my research of different family therapy models, brief strategic family therapy is currently the only one who has published data on reduction of parental substance use too. So if I'm seeing a young person who's struggling with really any substance and their parent also uses, we can see that kind of parallel decline of both use because we're changing those patterns. Next slide, please. Then we have multi-dimensional family therapy. So this is a therapy model that focuses on families with children 10 to 26. So it kind of expands those developmental ages. This one is a little bit more long-term, given that it can go up to 6 months, but it's about 1 session a week for up to 6 months. Again, we can extend it if needed to. This model is multimodal. So it might focus specifically on time with the youth, right? We're helping them build some of those social skills, helping them develop effective ways to communicate. And then treatment might shift a little bit, and we might kind of do, again, a parallel process in some regards. It might receive treatment, parents might receive treatment in providing support. If they're ones actively using, they're going to be learning a lot of different coping skills and ways to overcome. And then we work to then bring them together, have this integrative approach to where we're then practicing those enactments and engaging.
So you have a question in the chat. It says, do we have an idea of how many providers there are for these family therapy models in the state?
In my research, I know of people who have been trained. Which is like a handful, especially in multi-dimensional family therapy. We don't, to my knowledge, have any programs that are specific family therapy. So I can't say I'm certified in any family therapy model unless my whole team is, and I'm at that location, so they do sites. But I do know of like a handful of folks who have been trained in MDFT. I have not. I've met a few people who have gotten like the crash course on brief strategic family therapy. We're going to talk about MST, which is the multisystemic therapy. That's another one that is very intensive. So I don't know a number for that one. And then I know for CRAFT, we have 5 of our faculty here that have been trained. So we're working on some programming pieces to implement that.
But certainly not enough, right?
Not enough, not at all.
Not enough. And I think that's, that's one thing that Kristen has identified and is championing to bring towards West Virginia. So
absolutely. And even recognizing the disparities even across the state, like we're very lucky to be in Morgantown and have a lot of access to resources. However, we don't have fully trained family therapists. I'm sure some folks are. But even in some of the more impoverished areas of the state where we've seen many families get hit with addiction, not enough.
And a lot of families are seeing, and I know CPS refers to child advocacy centers, and it's certainly worth asking what model they use. And I was actually asking Kristen, is I'm like, in Morgantown, what model does our child advocacy center use? And we don't know. So it's giving you guys this information of these are the primary models that have evidence, and it's worth kind of knowing whether that kind of model is implemented in any way in the places where people are being referred to.
Well, and I definitely think when we're thinking about the level of trauma that a lot of families have exposed, we want to figure out which model can be most flexible to fit their needs. And MDFT might be some of that, right? Where I'm doing the parallel process initially, where I'm providing support for the youth and then pulling in family dynamics into that. How well is that implemented throughout the state? I'm not sure. But thinking though about the benefits of this model specifically with MDFT, so these are two separate studies that were conducted. The first one with the day treatment study was done in 2006, I believe, where they implemented the MDFT model within a day treatment program. So they did a lot of work at the day treatment, ended up going home, still family-based, and they were able to see this decline of youth being placed out of home. So about afterwards, I think it was 12 months or 9 months afterwards, 3% were still in the home, or were not placed outside of the home. The next one was MDFT in the community. So this was taking data from across the United States and seeing that about 90% had completed MDFT, did not have another repeat case of child abuse, and 90% of the youth stayed in the home. So really good data for this model, because not only does it then tackle, right, the individual. So again, in this situation, we're going to talk about the youth or the parent. There might be work with the youth too in that case. And then we're working on peer support. So within our friendships, so who am I hanging out with? Where are the safe places to go? How do I use assertiveness to decline offers from different people? Maybe there's even more community support. So I have mentors involved. Maybe I'm engaged more with my therapist. So being, again, this multi-system focus to help overcome these challenges. And now I'm blurry. Next slide, please. So then we talk about multi-systemic therapy. Very intensive in the research that I've done. This is one of the longer terms of treatment. It is family focused as well as community focused. So again, we're working to change this layer of treatment. It's very integrative with that. So 12 to 17, we're working on again, delinquency, substance use, emotional, behavioral disturbances that might be occurring, and figuring out where we need to work to make some of those changes within these systems. Next slide, please. So with MST, we focus on this theory of change. So we're working on family improvement of that functioning. Once we're able to solidify some of the better patterns, work on family integration, communication, comfort, attachment, all of the pieces, we then can bridge out to focus on other social supports. So we might be talking about and developing pro-social activities that our youth can do, be able to create connections with folks who maybe aren't using or are also in recovery over a period of time. This is why we see peer support so beneficial for our adult populations. We also target schools. So having lots of collaborative conversations with the schools, if there are behaviors occurring, if we're able to collaborate on academic success, being able to meet their needs. So again, the strength-based approach. I meet a lot of kids who can't sit in a classroom for whatever reason. So being able to connect them to maybe the VOTEC or work-related activities to keep them engaged. And then really highlighting the community piece. What community resources do we have to keep folks very engaged? So we might identify mentors. I was talking to one of my colleagues the other day, like how much I would wish we had a handful of jobs for some of the teens that I see that like we know the worker, we can work to connect with them and advocate to help them boost their skills instead of kind of, nope, you can't do these things out of fear. And all of those things together can work on reducing a long-term change or creating a long-term change for families.
There's a couple of comments in the chat, so I appreciate all the conversation in the chat. Teresa was talking about how positive behavioral support, which sounds like is that an evidence-based model, Teresa, that you guys use? And it sounds very similar to MST.
Yep.
I don't know if you can there you go.
Yeah, and looking at like the slide before this one, where we look at a behavior and then, you know, find the reason for the behavior and then develop the implement interventions and then implement the interventions and then review, and that looks very similar to positive behavior support. And so like maybe for a future thingy, Kelly, looking at the similarities and differences between positive behavior support and multisystemic therapy, because there are more people trained in positive behavior support in our state. And so if we can, you know, find a way to leverage that knowledge in a way that helps our families, you know, and our fellow citizens more, then I think that would be a good way to go in the future.
And is it a model that can be used both with an individual or a family, or is it typically an individually based model? Support.
The referral behavior usually comes from one person, but you know, positive behavior support says that no, that behavior is a form of communication and that it serves a function. And so oftentimes, like when I'm working with families, I will look at things that the family can do to change the environment, even if it's just a little bit, or to change their interactions with the person that has the referral behavior in an effort to prevent that behavior from needing to be exhibited. So, you know, if it's a communication thing, then if you establish the communication before the behavior, then it's less likely that the behavior will need to be accomplished. So, just as far as though the weird thing would be the difference between a therapy or a therapist or a counselor and a behavior specialist, because while I do all of this stuff, I do not have those letters behind my name that make me a therapist or a counselor. So it might be something to, you know, especially Kristen, if you're looking at bringing this kind of family therapy more into our state, it might be something that you can do to help leverage that.
Mm-hmm. Absolutely.
Thank you.
Thank you. Yeah, I think there's a lot of resources within the community that mimic or are very similar to what is happening. And absolutely, I think one, knowing more about what is out there and kind of developing a very expansive model for all of our families. One of the cool things that I like to mention about MST, so there's actually a lot of adaptations for MST. So the statistics here that are presented are specifically for child abuse and neglect. So it's the MST-CAN adaptation. And this data shows really the families who have experienced this type of family therapy model and the engagement of peers and school and community had really high results, really good results, right? 95% did not have a re-abuse incident after 16 months after receiving treatment. And again, even 91% of the youth reported no more PTSD symptoms past 16 months of treatment. So knowing what areas we're targeting, noticing the success of different models can be life-changing. Next slide, please. This is a very busy slide, and my apologies for that. I'm not going to spend a ton of time there. This might be one that we go back and reference at different points in time over care, but this is a comparison of each of these models. So what their focus are, where we would practice them at, and just again, like those comparisons. So brief strategic family therapy is a short term, it's very directive. So again, I might be intervening in the conflict that's happening in the moment, really focusing on resolution of the family conflict, improving communications, and decreasing concerning behaviors. MDFT is a bit longer. It is multidimensional. So being able to have multiple targets within that system. So I'm working on increasing peer interactions, school involvement, community engagement. It is very collaborative. So I'm going to include more of the systems and more of the players within those systems. MST is more intensive. It's typically completed at the home or out within the community. Again, same thing, multiple systems are involved. We know that behaviors happen across different platforms. So I'm going to, if I'm working with the adolescent, I'm going to work with the school, work on engaging peers, maybe give them different tasks. Community engagement, working with families to get more engaged, giving the parents more skills to be kind of, again, take over the parental roles within the family kind of across the board. I think the other piece to know, and I'll talk about this again in a few minutes, the cultural sensitivity of all of them. These all have cultural adaptations to them to meet every family regardless of their beliefs and backgrounds. So we can be really adaptive to what those experiences are. Next slide, please. So this is the craft. Was there a question?
I just wanted to interject, just looking at time wise. We do have two cases. So what we can do is we can save them and submit them like to the group and we can talk about them, or we can talk about them here because I just know we have about 5 minutes left. So it's up to you guys since you are the ones that submitted the cases.
And then Laura, I'll let you guys make that.
We submitted the cases to pull in as examples. I don't know, Laura, what do you like? I think we can finish the presentation and
Yeah, I feel like we have we have future sessions that have not yet been scheduled. And so if this is an area of interest for folks, I think we can transfer those cases and maybe do a brief update, because in the summer I put in the chat, we're hoping to incorporate the craft model into our treatment services, and then we could actually share with people where that is in its status and present some cases there. I know we have something that we need to plan for July and after that. So I think we'll stick with this. There is one comment I just wanted to mention that Richard put in the chat just about family treatment courts. I don't know what model that family treatment courts use for their family therapy interventions. And I don't know, Richard, if you know that.
No, I don't know off the top of my head. I'm just doing some research, and I saw that today's session was about family treatment, so I just didn't know if there was any input on that. But I certainly do not want to hijack the last 5 minutes. So, my email's in the chat if anyone wants to give me any feedback on that. We're looking at grant funding. And so I was just, I'm always looking to get input. So
Yeah.
I will be quiet now. If you have any input, feel free to email me. Thank you very much.
Okay, thanks.
Yeah, wonderful. We can go ahead and skip this slide because it's important, but not necessarily important that we have to talk about. CRAFT, so is the community reinforcement and family therapy approach. It is developed out of the community reinforcement approach. This can be done individually or within a group setting. It is about 12 sessions. It is very behavioral and person-centered. It does kind of what it is. We do a lot of group sessions or individual sessions revolving around homework, working on understanding behaviors. The important piece of this is that this is done with the family and does not include the person struggling with a substance use disorder. So if our parents and caregivers, they would be involved in that treatment, really helping them overcome the struggles they're experiencing, some of their own guilt and shame for maybe enabling or recognizing how their actions have been influential, and working on creating motivation within the setting of their home and of the lives of the person who is struggling to enter into treatment. So next slide, please. This slide I feel is important, recognizing that we know all of the research that we have looked at points that family involvement is going to change the outcomes significantly. So if we recognize that families getting their own help, it's improving the help and the likelihood of the loved person getting their own treatment. CRAFT has the data that says 7 out of 10 who received CRAFT, their loved one entered treatment shortly after the family completed CRAFT. So as Laura mentioned, we are working on getting our own program kind of up and running over the summer with CRAFT. So loved ones, it can be partners, parents, friends, really anyone who is wanting to find ways to support their loved ones. Yeah, so CRAFT is more for families. It doesn't typically include the person struggling with the substance use. And like I mentioned earlier, all of these models have been adapted over some period of time for a variety of different cultural backgrounds. However, we also want to be expansive and understand the person and the family as a whole to make the model work with them. Because there's not a one size fits all for all families or person.